Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is hyperkalemia. Normal range for potassium level in serum is 3.5 to 5.5 milliequivalent per liter. Hypokalemia is defined as serum potassium level less than 3.5 milliequivalent per liter, whereas hyperkalemia is defined as serum potassium level above 5.5 milliequivalent per liter. However, some lab uses 5 milliequivalent per liter as upper normal limit for serum potassium level. Let's understand potassium metabolism first. As you know, potassium is an intracellular cation and most of the body potassium is stored inside cells. Potassium is absorbed through intestine and comes into bloodstream where potassium level in serum is maintained between 3.5 to 5.5 milliequivalent per liter. There are two important physiological mechanisms by which serum potassium level is affected. When glucose enters into cell with the help of insulin, it takes potassium into the cell. When hydrogen ion concentration increases in acidosis, intracellular potassium ion is exchanged with hydrogen ion to maintain pH in normal range. Reverse will occur in alkalosis, where hydrogen ion concentration goes down. 90% of potassium excretion occurs through kidneys and 10% through sweat and other body fluids. Excretion of potassium through kidneys is affected by sodium load to which kidneys are exposed and aldosterone level. Hyperkalemia can be caused due to excess intake of potassium. It can also be caused due to increased shift of potassium from intracellular to extracellular compartment. This can occur physiologically in acidosis or diabetic ketoacidosis. Sometimes cells rupture and release potassium into bloodstream. This can occur in tumor lysis syndrome, hemolysis, rhabdomyolysis, crush injury, etc. Hyperkalemia can also be caused due to decreased renal excretion. This can occur in end-stage renal disease, aldosterone deficiency, potassium-sparing diuretics like spironolactone, or use of other drugs like ACE inhibitor, enalapril, angiotensin II receptor blocker like telmisartan, and NSAID like aceclofenac. When serum potassium level is in normal range, ECG is also normal. When serum potassium level is between 5.5 to 6.5 milliequivalent per liter, first ECG change will be tall peaked asymmetric T wave. Peculiarity of tall T wave in hyperkalemia is that slope of ascending limb of T wave is steeper than descending limb, which is in contrast to normal T wave, where slope of descending limb is steeper than ascending limb. QT interval is shortened. When serum potassium level is between 6.5 to 8 milliequivalent per liter, along with T wave changes, P wave diminishes in amplitude and may disappear. PR interval is prolonged. QRS complexes are widened. When serum potassium level is more than 8 milliequivalent per liter, P wave disappears. QRS complexes merges with tall T wave to form sine wave pattern. At this level, there is high risk of developing torsades de pointes, which is a form of polymorphic ventricular tachycardia. In this ECG, there are tall peak T wave in precordial leads. On looking closely, tall T wave have steeper slope of ascending limb than descending limb. QRS complexes are wide and P waves are absent. All these features are suggestive of hyperkalemia. In cases of hyperkalemia, first ECG should be done to look for changes of hyperkalemia. But if ECG is normal, then potassium level should be rechecked, as hemolyzed sample can cause falsely high level of potassium. Before investigating further, one should exclude history of excessive potassium intake and use of drug causing hyperkalemia. Blood sugar level and arterial blood gas analysis should be done to rule out diabetic ketoacidosis and other acidosis. Kidney function test should be done to rule out end-stage renal disease. Serum uric acid and phosphorus levels are raised in cases of tumor lysis syndrome. CPK total level is raised in cases of rhabdomyolysis. Serum LDH and haptoglobin levels are raised in cases of hemolysis. If no clue is found for underlying cause of hyperkalemia with the above investigation, then urine potassium, urine osmolarity, serum renin and serum aldosterone level should be done. For treatment of hyperkalemia, one should first remove sources of excess potassium and stop medications causing hyperkalemia. IV dextrose 25% 100 ml with 10 unit of regular insulin, IV sodium bicarbonate and beta-adrenergic agonists like salbutamol given by nebulizations are the modalities used to shift potassium to intracellular compartment. IV calcium gluconate is used to counter physiological effect of potassium. One should remember that calcium gluconate does not decrease serum potassium level, but prevents development of arrhythmias induced by hyperkalemia. Loop diuretics are used to enhance potassium excretion from kidneys and to reduce potassium absorption from gastrointestinal tract. Cationic exchange resins like sodium polystyrene sulfonate are used. If all these modalities does not improve hyperkalemia, then hemodialysis is the only option. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.